Okay, in Unit 4, we're going to talk about some testing that gets done prior to patients receiving a transfusion. Then we're going to talk about transfusion reactions and the work that has to be done to resolve any type of transfusion reaction. Then we're going to talk about different preparation of various blood components and donor requirements. So this first video is going to be a little bit shorter. We're just talking about pre-transfusion testing in this one. Okay, so compatibility testing, the principles of the cross match. So the cross match is what is the testing that we do that tests the recipient's blood. So that's a patient who needs a blood transfusion. So the recipient's blood against a donor's blood. So the donor's blood are the units that we keep in the blood bank that are from donors that go to the recipient. So tests the recipient's blood against a donor's blood to determine compatibility. So we have to make sure that that donor unit is compatible for transfusion to the patient. So this is a requirement for all red cell transfusions. The exception would be in situations requiring an urgent need for blood. So that's referred to as an emergency release. So if you have a patient come into the hospital, a lot of times emergency release situations will happen when the patient's in the ER and they are bleeding out, or they are in the OR and bleeding out. Occasionally you might have something like that happen to a patient who's already been admitted to the floor. But so in the case of the emergency release, the goal is to get that blood that the patient is losing, get that blood replaced as quickly as possible. So in that case, we issue O negative blood that does not get cross-matched until afterwards. Okay, so the cross-match includes all the steps in the identification and testing of a transfusion recipient with donor blood before the transfusion to provide a blood product that survives in vivo. And we want to do that because, again, there's something going on with that patient that has put them in a need for transfused red cells. So it's supposed to be beneficial to the recipient. We do not want to introduce a foreign antigen because we've talked about up until now, patients can build antibodies when they are exposed to an antigen that they do not already have, and that's done through pregnancy or transfusion. So we want to try to prevent that. So this compatibility cross-match process begins with the transfusion request. So the doctor enters an order for a transfusion. It ends with the transfusion of the blood to the patient. So that whole process includes an antibody screen, ABO and Rh phenotyping. So we have to determine the patient's blood type. We have to do the antibody screen to determine if they have any antibodies. And then it includes the donor testing and cross-matching. If the patient were to be identified to have an antibody, then we, of course, would have to do that full antibody panel workup to determine what the antibody is and then find units that would be compatible. Okay, so the principle of the cross-match, prevention of life-threatening, uncomfortable transfusion reactions, and to maximize in vivo survival of transfused red cells. So this is routinely performed only with donor products that contain red cells. So it has to be performed for red cell transfusions. And again, the exception to that would be emergency release situations. And in those situations, we would issue a unit of O negative blood, but that doesn't mean that we don't have to do that testing kind of on the back end. We're going to issue the blood so that the patient can start the transfusion, so that we're helping to save this patient's life, but we're still going to do the ABO and Rh. We're still going to do the antibody screen. It just gets done after the issue of the blood in that case. Okay, so the cross-match involves mixing the recipient's serum or plasma with the donor's red cells. and it's interpreted as compatible if there is no agglutination present. Because remember, and it's interpreted as incompatible when agglutination is present. So why would that agglutination be happening? It's happening if the antigen has found its antibody that it corresponds with. They come together like that lock and key mechanism, and they agglutinate. So if we're testing the patient's serum or plasma, that's where the antibodies are located, testing it against the donor's red cells, which is where the antigens are located. If that patient has an antibody to an antigen that the donor unit has, then you're going to see agglutination. That would mean that that unit is not compatible. It serves as a double check of any ABO errors that might occur also, that might occur because of patient misidentification, or maybe the donor unit was mislabeled. I've never seen that happen, but it could happen. It also serves as a means of antibody detection and checks the results of the antibody screen. So if we're getting an incompatibility when we're doing our cross match, that would indicate that some kind of testing was incorrect in the antibody screen, we might want to go back and do some retesting. A post-transfusion H&H value should be evaluated for a successful transfusion. So presumably the patient has had either a CBC or an H&H done before the transfusion, and that's what determined the need for the transfusion. Then they're going to transfuse the red cells, and then they want to do an H&H after the transfusion to make sure that it was successful. So 1 unit of red cells should increase the hematocrit by 3% and the hemoglobin by 1 gram per deciliter. Okay, the recipient blood sample. So before we start any testing, the patient history should be checked for previous ABO-RH result to see if the patient has a history of antibodies, if there had been any difficulties in testing and typing previously, any kind of transfusions reactions or special requirements. So if that patient has had any type of work, blood bank work done previously, either at your facility or at another facility where your medical records are linked, you want to check that information, and that's going to help you kind of be on the lookout. And it serves kind of as a double check also. If you've got a record of this patient in your medical record system that says that the patient's type A positive, and then you test it and you're coming up with A negative, then that's a discrepancy that you would need to resolve. So all of that information kind of serves as a double check. The patient has to be identified properly with 2 patient identifiers, and there's going to be a special blood bank number. So if a blood bank sample is drawn from the patient, it's collected in a slightly different way than other blood samples would be collected, and it's associated with a specific blood bank number. So that patient has to have that blood bank number. Most hemolytic transfusion reactions occur due to misidentification of the patient or sample labeling errors. So we want to make sure that we get that simple part of the process correct. The tubes should be labeled in the presence of the patient. We never want to pre-label tubes. The patient sample that's used can be plasma or serum. So what we do is collect an EDTA tube or a plain red that has no additives in it. The sample cannot be hemolyzed, so if it is, we would have to send for a recollect. Sample has to be collected no more than 3 days or 72 hours before a scheduled transfusion or procedure, which just ensures that the sample reflects the recipient's current immunologic status. So if we have patients who have surgery scheduled, usually we have them come in sometime within that 72 hours prior to the scheduled surgery and have a type and screen done. If for some reason that surgery worked, say it got delayed by 1 day, as long as that patient still has that blood bank bracelet on and the patient has not received any blood products during that time, you can extend that cross match. but that's only in like certain situations where that would happen. So you've got a patient sample and a donor segment. So each donor unit of red cells has little like samples that are attached to that blood bag so that you can pull those little segments off for testing. So you have to save the patient's serum or plasma with the red cells and that segment. So again, it's just that sealed piece of tubing from that donor unit bag that contains a small aliquot of the donor blood. And that's what we use for testing. So either in the initial spin or antiglobulin cross-match. Okay, the immediate spin cross-match. So if you see the letters IS, that abbreviation stands for immediate spin. So an immediate spin cross-match can be used for recipients with no evidence of clinically significant antibodies in the current sample or in their patient history. So if you have not identified, the patient does not currently have a positive antibody screen, they do not have any history of a previous positive antibody screen, then we can do just an immediate spin cross-match. The recipient serum or plasma is mixed with the donor red cells. They get centrifuged, and then we're looking for agglutination. So there's no incubation step there. It's just a couple drops of patient, couple drops of donor, spin and read that reaction. There should be no delay in the centrifugation step or in reading the reaction. This can lead to false negative results, and you might miss an ABO incompatibility. I want to say this again. I think I said it just a minute ago, but I think I didn't get the whole point out there. But anytime that a cross match is done and a patient receives a red cell transfusion, we have to save that patient sample and the donor segment for 14 days after the transfusion. And that's just in case that a transfusion reaction were to occur. There can be some cases of delayed transfusion reactions, and if that happens, we have to retest those samples. So if that investigation is necessary, then we have the samples to do that with. Okay, I just went through the serologic cross-match. Okay, a computer or electronic cross-match. So this uses a computer to make the final check of ABO compatibility in the selection of appropriate units for transfusion. So again, that patient we cannot currently have identified an antibody, or the patient can't have a current positive antibody screen. The patient cannot have a history of a positive antibody screen. There has to be on-site computer validation that was performed. So ABO compatible whole blood or red cell components have to have been selected accurately for transfusion by the computer system. There has to be 2 determinations on file of that recipient's ABO group. One must have been completed on the current sample, and then the second one either has to have been like a history of the patient's ABO and RH from a previous visit, or you have the option also of doing the second determination at the same time, but it has to be from a different sample. The donor unit information, so it has to have the product name. So is it red cells? Is it fresh frozen plasma? Is it cryoprecipitate? So it has to have that product name identified on it. It has to have the ABO and RH identified on the label, the number, interpretation of the confirmation test. So for the recipient information, we have to have 2 identifiers. The recipient's ABO and RH typing has to have been done, antibody screen results, and then the interpretation of the compatibility of the patient with the donor. So, and then in this case, there's computer software that's able to identify a unit that is a donor unit that's compatible. So it takes that information that you've given the system, you've performed the ABO-RH, you've entered that into the system, and then the system selects a compatible unit of blood based on the results of that ABO-RH, the negative antibody screen, and the inventory that the computer knows is available. There has to be a method to verify correct entry of all data before the release of the blood or blood components. And so some of the advantages of electronic cross-match, it saves time. There's reduced volume of sample needed, and then just better management of the blood bank inventory, because the computer's going to pick the one that's compatible, that maybe is getting ready to go out of date. So it's going to pick the best one that's available. Okay. So selection of donor units. So it should be ABO identical when possible. That's not always possible. With blood plasma products, ABO antibodies in the transfused plasma should be compatible with the recipient's red cells. D positive blood should be selected for D positive recipients. D negative recipients should receive only D negative blood in order to avoid immunization to that D antigen, because remember, if we're exposing a patient to an antigen that they do not have, they're going to start to build antibodies. If the recipient has antibodies, then they should receive antigen negative blood. So we do an antibody screen, we determine that the patient has an antibody, we do the full antibody panel to identify what the antibody is. Once we've identified that antibody, we have to screen all of the donor units to make sure that they are antigen negative. Because again, what happens when the antigen and corresponding antibody meet, that lock and key mechanism that results in agglutination. If the patient is negative for an antigen, an antibody will be made on the first exposure to the foreign antigen. So if the patient has a negative antibody screen, we're not going to phenotype the patient and the donor sample to make sure that we're not giving them any antigens that they don't already have. That is just kind of a likely consequence of patients receiving blood transfusions. But if the patient has an antibody, we want to make sure not to introduce the corresponding antigen through blood transfusion, because that's where we have transfusion reactions. Okay, and here's just a chart that shows what units would be compatible based on the patient's blood type. So if the patient is a type O, they can receive type O whole blood. They can receive A or O red cells. They can receive A or AB plasma, and so on and so forth. Okay, when we are issuing blood products, so once that compatibility testing is complete, we've got those results on file, a label is produced and it gets attached to the donor unit that identifies it as quote unquote tagged to the recipient who it was tested for. So that label, once we've done that cross match and we've identified a unit that's compatible for our patient, the label that gets printed out that we put on that unit has to have the patient's full name, their hospital medical record number, and that unique blood bank number that's on their blood bank bracelet. Has to have the name of the product. So again, is it packed red cells? Is it fresh frozen plasma or something else? And that unit is going to have a specific identifier on it, a number that's a unique identifier given to that product by the blood product supplier. So whoever you get your blood products from has an expiration date on the product, and it identifies the ABO and RH of that unit. So we also have to have a physician's order on file for that transfusion. We have to check it carefully against the unit tag and the unit label. So when the nurse comes to pick up that unit for that patient, we go through all of those checks side by side. So they have to bring some type of identification for that patient that we're comparing to the information that we have on the patient. So, you know, I'm reading off the patient's name, their medical record number, their ABO-RH, then we go through that donor unit number, double check against the unit's ABO-RH. So there are all these checks that get that are put in place. We also have to check the unit visually just to make sure that nothing looks weird about it. Is it discolored? Are you seeing clots? Just anything that looks weird about that unit. We also have to notate the date and time that we issue that unit, the name of the nurse that's picking up the unit. We have to document that. After the transfusion is complete, that tag that we had on that unit with all of the patient's information then gets attached to the patient's chart. And unless that, so once that unit leaves the blood bank, unless it is stored in a monitored refrigerator, meaning that it has a calibrated thermometer in it that is monitored regularly and that temperature notated at regular intervals. So unless it's stored in a monitored refrigerator, any unused red cell units have to be returned to blood bank within 30 minutes. If they're not used for whatever reason, so it has to be returned within 30 minutes to allow for reissue. If they don't get returned within that 30 minutes, or if it is longer than 30 minutes and they're kept in a monitored refrigerator, that would be an exception. Otherwise, we have to discard that unit. So that whatever the cost of that unit was goes in the trash also. And I will say the standard is 30 minutes. I think our hospital policy now is 20 minutes, so that might be somewhat hospital specific. Okay, urgent transfusions or emergency release, as they're more commonly referred to as, may be done in bleeding emergencies when there's no time to complete all of that pre-transfusion testing prior to the transfusion being given to the patient. So the doctor has to look at the risks of transfusing uncross-matched blood versus the delay required for completion of that compatibility testing. So if emergency release is requested, certain criteria have to be met. And I will just take a second to say most blood bank facilities now have automated instruments that you can put the sample on. It'll determine the patient's ABO and RH. It'll do cross-matching. It'll do the antibody screen, which is very nice to be able to put that sample on and then walk away, because then you can do something else. But most of the time that takes longer than doing the testing on the bench. So you're talking on the bench, you could probably get an ABO-RH antibody screen done in 20 to 30 minutes. It might be closer to 45 minutes if you're doing it automated. So the doctor just has to kind of take into consideration how long is it going to take me to get blood for this patient who is in the midst of a bleeding emergency. If an emergency release is requested, the criteria that has to be met, we have to issue type O red cells if the patient's type is unknown. We have to issue D negative blood if the D type is unknown, especially if the patient is a female of childbearing age. D positive blood is acceptable for men and postmenopausal women. So if it came down to an issue of inventory, say maybe you didn't have any D negative units for whatever reason, you could issue D positive to men or postmenopausal women. Or if you were saving the O negative units for something else, I don't know. A release has to be signed by the ordering physician. There's going to be a tag on the unit that indicates that it is indicated for emergency release, and it's going to be labeled as uncross-matched. And then the following information should still be checked when the unit is issued. So you're still going to check the patient's name and identifiers to make sure that you're issuing that blood to the correct patient, that donor unit number, the ABO and D phenotype of the unit, the expiration date on the unit, the name of the tech that issues the unit, and the nurse that's picking the unit up has to sign and date that emergency release form. You also still have to save segments from that unit because you are going to be cross-matching that blood. You just haven't gotten that patient sample yet. So you're going to save segments so that that cross-matching can be done. All that information still has to be on file. And you want to save at least one segment for that 7 to 14 day hold in case there is a transfusion reaction. So pre-transfusion samples and a recent transfusion history or desirable if that's possible. And if it's depending on how emergent that situation is, it may not be possible. So the most important test to complete is that ABO and RH. You want to do that as soon as the sample is received, and then begin that type and screen and cross-matching of the units that have already been issued. Because we want to have that information on file. We need to enter it into the LIS and want to make sure that there is not a possibility for a transfusion reaction. Any positive results in the screen, antibody ID, or antiglobulin cross-matching would have to be noted, and the doctor would have to be informed. So again, the patient's already been given that blood, and we're doing the testing that would normally be done prior to that transfusion. We're doing it after the transfusion is already complete or it's underway. So if anything comes up during that testing, we would have to notify the doctor. And then testing for additional units. So if the patient needs additional units for transfusion, that you should go ahead and initiate that. Especially if those units can be hard to find if the patient does have an antibody. So during emergencies, personnel should anticipate preparing platelets, thawing cryoprecipitant, FFP, and cross-matching additional red cell units in advance. So once you've got that initial emergency release done, hopefully you've gotten a patient sample by then, and you're doing all of your ABO, RH, antibody screen testing, then you can start selecting compatible units. Platelets, plasma, and cryoprecipitate contain almost no red cells, so they don't have to be cross-matched. Plasma is the blood component prepared from whole blood that contains only the plasma portion of the whole blood. It is frozen after separation, so it's referred to as FFP, or fresh frozen plasma. So it's frozen after preparation, but then we thaw it prior to it being transfused. Platelets are a concentrate of platelets separated from a single unit of whole blood. So it should contain a minimum of 5.5 times 10 to the 10 platelets. And then cryoprecipitate is a blood component recovered from a controlled thaw. So there's a special thawing process of FFP. And then the cold insoluble precipitate is rich in coag factor 8, which is von Willebrand's factor, and factor 13 and fibrinogen. Selection of blood products after a non-group specific transfusion. So since type O blood is given in emergencies, since it's compatible with every blood type, and it contains minimal amounts of anti-A or anti-B, the patient can be switched to type-specific blood immediately once you've received that blood bank sample and you've done all that appropriate testing. If passively acquired ABO antibodies start to demonstrate, which can happen in cases of massive transfusion, the patient could have a positive DAT and transfusion with red cells lacking the corresponding ABO antigens can be given. Okay, and then finally, blood inventory management. So inventory in the blood bank is maintained according to that facility's procedure. And a lot of that's going to depend on the type of facility they are. Are they a trauma center? Are they an oncology outpatient clinic? So what kind of patients do you serve? How many units is it normal for you to give out in a day or a week? And you have to monitor that blood use and that need daily. So usually what you're going to do in the morning when you come into the blood bank department, you're going to take inventory daily. You're going to see how much blood you have on hand, determine if you need to order any to keep in your inventory for that day. And a lot of times, depending on the available blood supply from your blood distributor, a lot of times units, like especially O negative, are in short supply, and they will only allow you to order O negative units if you have a patient that's immediately needing those units. Patients scheduled for surgery are going to get they're going to have a type and screen to have on hand, and then the doctor can order a cross match if needed during the procedure. So, and then that's just standard. Like I mentioned a few minutes ago, if a patient is scheduled for surgery, they're going to have that patient come in to do that testing sometime within the 3 days prior to their scheduled surgery date, so that we have that blood sample from them on file. We have their type and screen already available, and that information's in the system, so that if something were to happen during that procedure, we're much more capable of responding quickly to that situation. So that's the end of this first lecture video. In the next one, we'll talk about some of those adverse transfusion reactions that can happen, and the transfusion reaction workups, or the testing that we would do in those cases.